And as I unshare my screen, I will go ahead and ask Dr. Kelli DeLay to start sharing her screen. And as she's doing so, I'd like to introduce her. Dr. DeLay is an assistant professor of medicine at the University of Colorado. She is an experienced esophagologist and takes care of patients at our Rocky Mountain Regional VA Hospital, as well as the University of Colorado. And a hot topic, as it always is, we're really excited to hear about her perspective on some treatment challenges in eosinophilic esophagitis. Dr. DeLay, thank you so much for being with us this morning.
Thank you, Dr. Patel. Welcome, everyone, and good morning. And I want to thank the course directors for inviting me to speak today. I have no disclosures. Our agenda today is to identify features of eosinophilic esophagitis, review the diagnostic workup and management, recognize pitfalls and apply tips for esophageal biopsies and examine treatment options after we do this, address difficult or treatment refractory patients, quote unquote, and discuss a method for dietary reintroduction in patients who have decided to do the elimination diet. So the connection between food and EOE was looked at in a landmark study at Johns Hopkins in 1995. And this was looking at a group of pediatric patients that had reflux type symptoms and esophageal eosinophilia on biopsies. But all of the therapies aimed at treating reflux didn't actually improve any of those symptoms. And the histopathology didn't change either. And it wasn't until they put these patients on elimination diet or an elemental diet that excluded dietary protein that they actually saw improvement in symptoms and pathology. And so this was really the first study and the first connection that we had of food to EOE. In population-based studies, primarily conducted in Europe and North America, they've been looking at the incidence of EOE and found in all of these studies that the incidence is rapidly increasing. In the US, currently prevalence is about 1 in 200. So what is EOE? Key points are that it's a chronic immune-mediated inflammatory condition of the esophagus. It is food antigen driven, with the caveat that there is likely other contributors, environmental contributors to this, that we still have yet to suss out. And it's frequently associated with atopic conditions like asthma, rhinitis, allergic rhinitis, and eczema. When we think of the disease activity of EOE, it's very important to think of not only inflammation, which is the esophageal eosinophilia, but also tissue remodeling, this transmural process that we see with EOE. This can occur with mucosal expansion. We see subepithelial fibrosis, and it really affects the motility of the esophagus. We evaluate this with an EGD and/or an esophagram. So current guidelines recommend that any patient diagnosed with EOE should be offered our typical therapies of PPI, topical steroids, or elimination diet. But we know that patients with EOE are an homogeneous population and that different phenotypes exist. And these phenotypes can affect the age of presentation, their severity of disease in response to different therapies, the fibrosis that may occur, and the atopic comorbidities they might have. Additionally, there are associated conditions like inflammatory bowel disease or connective tissue disease that has been associated with EOE. And so future research is really needed to look at these atopic versus non-atopic pathways to see if there's a difference in the natural history of disease, their response rates, their risk of progression. So let's dive into a case. This is a 27-year-old male who's presenting with dysphagia. His index endoscopy showed those classic endoscopic features of EOE, rings, furrows, and his biopsies had 23 eosinophils per high power field. So he was started on high-dose PPI therapy, but did not have any symptomatic improvement. So what should we do next? It's important to always take a systematic approach when treating patients with EOE, especially in those who don't respond initially to the treatment you've initiated. So for this patient, we would move forward with an upper endoscopy to reevaluate the burden of disease. And in him, if we saw persistent endoscopic and histologic disease, then we have a few options. We could switch to steroids, we could switch to an elimination diet, and then we often get the question, what do we do with the PPI? Should we choose these different pathways? And in general, especially if they have reflux symptoms, we'll keep patients on PPI for dietary therapy through the elimination and the reintroduction phase to not confound results, and then later try to wean off, especially if they don't have reflux symptoms. So for this patient, we transition to topical steroids and we keep the PPI as discussed, but after 8 weeks, his dysphagia has only minimally improved. So we have to think and make sure we're deciding that the eosinophils we've detected is actually the cause of patient symptoms. And also remember that eosinophils found may not always be related to EOE. So most commonly, it's related to EOE and GERD. However, there are other disease processes that we see esophageal eosinophilia, like connective tissue disease, inflammatory bowel disease, achalasia, or even pill esophagitis. And so if something isn't making sense, if we're not getting improvement on typical therapies, one thought is to think about these other potential connected disorders that we might be missing. So back to our case. After we've assessed, we think that this truly is EOE. We want to know, is the patient adherent to the diet? Is he adherent to the medications? Is he giving the medications appropriately? Are there superimposed infections that might be complicating treatment response? Or is there some ongoing allergen trigger we just have not identified yet for him? And we always want to think, in what realm are the patients not responding? Because we know that EOE is not only symptom driven or clinical driven, but also it's an endoscopic and a pathologic diagnosis. So the symptoms that we typically see are dysphagia, atypical chest pain, and patients have often had a history of food impaction. That pathology, of course, shows us that there is one or more biopsies with greater than 15 eosinophils per high power field, and other causes of eosinophilia have been excluded. And then the endoscopic features of EOE. And so these are panels of different classic features of EOE, from the edema or the lack or loss of vascular pattern to the rings that we see in B, the furrows that we see in panel C with those longitudinal furrows moving down the esophagus. D is showing us a narrow caliber or strictured esophagus. And E is that classic, as UNC describes, that tug sign, which is a marker of the subepithelial fibrosis that can make pulling those biopsies off just feel a little tough. And panel F is crepe paper esophagus, which is to dilate the esophagus with passage of the gastroscope alone. Remember that the number one cause of food impaction is EOE. And so this is generally a 2 a.m. call that we are called in to remove food or push food through. And this is an important time for gastroenterologists to take biopsies at that same time and move forward the diagnosis of EOE should it be there. And also make sure that patients are referred to a gastroenterologist for follow-up. Biopsy tips. Make sure that we're increasing the yield by biopsying areas of inflammation. So those are the exudates and the furrows that we see. Target those regions. Know that there's no location of esophageal eosinophilia that's been shown to predict EOE versus GERD or response to PPI. And so in patients that might have the jar from distal esophageal biopsies that show eosinophilia, that does not necessarily mean that this is GERD or that they're going to respond to PPI. And this might also be important in our population that is charged based on the jars that are sent down. You may want to consider putting all of your biopsies in one jar, given that there's no difference in EOE versus GERD or response to PPI based on location. And then peak counts are variable throughout the esophagus. So this is an esophagectomy specimen from a patient with EOE, and they were able to get longitudinal levels circumferentially. And the red line here represents that diagnostic marker of 15 eosinophils per high power field. And you can see the biopsies in the surface area that fall below that 15 eosinophil threshold. And so if you're biopsying in one of these many, many areas, you may actually miss the burden of disease or the disease itself that's actually present. Back to our case. So patient is still complaining of dysphagia, but an EGD showed only 4 eosinophils per high power field, which is considered to be in remission or good control of inflammation, and only mild endoscopic findings of EOE. So at this point, we have endoscopic and histologic improvement, but symptoms are still persisting. And so we want to think about dilating. So why do we dilate an EOE? Well, endoscopic improvements with topical steroids tend to be just related to those endoscopic findings of exudates, edema, plaques, and rings. And we know that strictures have not generally improved with steroid therapy or resolved with any anti-inflammatory therapy. So even if you have histologic and endoscopic improvement and they're still having symptoms, there may be subtle stricturing that we've missed. So there's not one safest or most effective way to dilate an EOE. Generally, when we have a full narrow caliber esophagus, we'll go for the wire-guided savory dilation. And for focal strictures, we'll do through the scope balloon dilation. There's also the pull-through technique as described by the UNC faculty that could be employed. And an important point here is remember to tell your patients that they might have chest pain, and in this patient, he likely will have chest pain after dilation, and that might be something to consider when choosing your diet for that night or the next day, or to know that it's coming to anticipate that. So why use both therapy and dilation? On the flip side, we know that dilation does not improve inflammation. And so again, Dr. Dellen's group at UNC looked at patients that had been on topical steroids for 8 weeks and divided them into the histologic responders and the non-responders based on that 15 eosinophil per high power field. And they found, and you can see here, that in the histologic responders, they required less than half of the absolute number of dilations than the histologic non-responders. And that's important in terms of procedure sedation, losing work time, etc. So treatment of EOE, we divided into the 3Ds, and we remember that drugs are proton pump inhibitors, topical steroids, and biologics. There are no FDA-approved medications for EOE, and so the medications that we use are often asthma drugs. Diet, we have the empiric elimination diet or allergy-directed diet, and then dilation. And as we discussed, we want to combine that with therapy. As a caveat, proton pump inhibitors, why do they work? Well, a patient may have both GERD and EOE. Erosive esophagitis from GERD can affect that epithelial integrity and compromise that, and so you may have increased antigen exposure that way. And then PPIs, we know, have a role in the inflammatory cascade contributing to eosinophilic migration through that eotaxin 3. There also may be the fact that the motility that's, the dysmotility, excuse me, that's caused by EOE may affect the ability to clear reflux, and that may contribute to GERD. So what do we do with our truly treatment refractory patients when we've considered all of these things and we found that they really didn't respond to any of our classic therapies? Well, coming down the pike is our biologic therapy. So IL-13 and IL-4 pathways have been implicated in allergic diseases, including EOE. And there are 3 biologics right now with promising results. Maybe the most commonly described is the anti-IL-4 and 13, which is dupilumab. We also have the anti-Siglec-8 receptor antagonist, which is found on eosinophils and mast cells. And that's available in trials at the university. And then we have an anti-IL-13, the RPC 4046, and this had a primary outcome of histologic improvement. Dupilumab, again, blocks IL-4 and 13, and in this phase 2 trial, found that it significantly improved dysphagia, severity of histologic and endoscopic features, eosinophil count, and the distensibility of the esophagus. And actually, in part A of randomized placebo-controlled phase 3 trials, these findings have also been significant. You may be wondering, and it's reasonable to wonder, why we need new treatments for EOE. Well, there is not a small number of patients who just don't have response to steroids, and also a loss of effective steroids after time. There's also the burden of dietary therapy, and adherence to that therapy over time may be very difficult. And then we've alluded to the severe disease. So these disease phenotypes, we commonly think of chronic inflammation being the biggest risk factor for fibrostenotic disease, but some research done by Dr. Kelli Menard-Ketcher has shown that there are some children who are presenting early on with fibrostenotic disease, and that's suggestive of these severe phenotypes that may not respond to our classic therapies. The elimination diet, so classically described as the 6-food elimination diet. By far, cow's milk is the biggest trigger for EOE, followed by wheat and egg, soy, legumes, and tree nuts, and very rarely seafood or fish has been shown to be the trigger for EOE. So the 6-food elimination diet, we've also looked at the 4-food elimination diet. There is the 2-food elimination diet with a step-up approach, or the 2-4-6 method. And so this was first assessed by a group, Molina Infante's group in Spain. This was a group of 130 patients who underwent a 2-food elimination diet. It was milk and gluten that was eliminated, that induced remission in 43%. And in those who didn't respond to the 2-food, they were escalated to the 4-food elimination diet. And if they didn't respond to that, eventually the 6-food elimination diet. And so in this step-up therapy, stepping up to the 4 and the 6-food elimination diet led to similar remission rates that's previously been reported with those elimination diets. And compared to the 6-food elimination diet, this was great because it allowed reduction of the number of endoscopic procedures that patients had and also shortened that diagnostic process time. So these are histologic rates I alluded to. In patients on the 6-food elimination diet, 70 or more % of patients will be in remission, 50% for the 4-food elimination diet, and down to 44% for milk and wheat. And remember that 80% of patients will have a single food trigger identified. But it can be difficult to know, and there's more than one way to reintroduce foods after the 6-food elimination diet. And so this is one method I'm going to outline, and this is modeled after what they're doing at Northwestern University in Chicago. And so after at least 6 weeks of 6-food elimination, you could add seafood for 2 weeks, add nuts for 2 weeks, and then perform an EGD. If there's greater than 15 eosinophils still per high power field, you would do at least a 6-week washout, end that washout, and then move to a single food trial. So adding nuts back and then doing an EGD, or adding seafood back and then an EGD. But if there was fewer than 15 eosinophils per high power field, then you would add soy for 2 weeks, add eggs for 2 weeks, and perform another EGD. Again, if greater than 15 eosinophils per high power field results in a 6-week washout, ending the washout and moving to a single food trial of just soy or just eggs. Again, if there was histologic control of inflammation after adding soy and eggs, then you would add wheat for 4 weeks. And if there were greater than 15 eosinophils, a little bit different here, after ending the washout, you'd move to a single food trial, and that would just be dairy for 4 weeks, and then an EGD to evaluate for improvement. There are allergy-based elimination diets, the skin prick, serum IgE, and atopic patch testing. And doing so, those positive results will determine which foods are eliminated. But in studies by Molina Infante, this is a meta-analysis that he did, almost 50% of patients failed to achieve remission on these allergy-based testing diets, compared to 87% of patients who had been on topical steroids. So the caveat here is that we need to know a lot more about aeroallergens, and patch testing may be better than the others, but there's still not great data to support that this is a good way to target elimination diets. Should repeat EGD be used to assess patients with eosinophilic esophagitis after we change therapy? In general, yes. We're missing large, good quality studies, but we know that there's not a great linear relationship between symptoms and biologic activity. And so even if a patient's saying that they feel better, it's good to go in and make sure that that inflammation is under control. Who might be a candidate for maintaining therapy for a long time? Well, those who've had a narrow caliber esophagus, who've had recurrent food impactions, who may have had a complication like a perforation during a procedure in the past, who's rapidly getting symptoms back after they stop therapy, or who have other comorbid conditions that may increase their risk of sedation, endoscopy, and dilation. So future directions. We need studies that show us uniform endpoints among clinical trials for comparisons between therapies and head-to-head studies. We also need to know the effectiveness of this combination treatment, since patients are often on more than one. Researchers are actively investigating less invasive, more efficient ways to diagnose EOE. We need to look at phenotype and different endotypes of EOE for precision medicine to try and target therapy for specific individuals. We need to look at environmental triggers. There are epidemiologic studies that show that EOE is more common in cold, dry, arid, and rural climates, and we don't exactly know why. We need to know about testing, aeroallergen testing, serum biomarkers, and the EOE transcriptome. So in summary, we learned today we need to take multiple biopsies from multiple levels and use our clinical context to diagnose EOE, use a systematic approach when we're treating EOE, particularly in patients who don't respond to the first-line treatment. When symptoms occur, we know that there's not a great linear relationship with esophageal eosinophilia, so it's important to go back in, do an endoscopy, and evaluate burden of disease. The treatment of EOE is those 3 Ds: drugs, diet, and dilate. Dilate with the therapy. There are no FDA-approved medications for EOE, but there are biologics coming down the pike that we may have for treatment refractory patients. And we know that dilation, when combined with therapy, reduces the number of future dilations and should definitely be considered in patients. Thank you so much.
Thank you, Dr. DeLay. That was an outstanding overview of our approach to treatment in EOE. And there have already been a bunch of questions come through the Q&A box as well as the chat. So I'm excited for a lively discussion during the panel.